Hallie Robinette. I am the president of the Hawaii Public Health Association, and it's my honor and privilege to welcome you all to this first webinar, hopefully in the series of webinars that HPHA will be offering in response not only to the COVID pandemic, but also to other pressing issues as we know happen in the world of public health. So let me get started. Can you all see the screen here with this first slide, introduction slide with the title?
Yes.
Yes.
Okay. Just to let you know, this webinar is being recorded for those who are not able to join us today. We hope to have it up on our website later this week. So look for that if you're interested in the recording. Okay, let's see. I can advance this. Let me introduce the speakers. We are very fortunate to have two highly distinguished leaders in the lab science world. I didn't quite realize this until I started researching and preparing for this webinar, but both bring many years of experience to their position. Dr. Edward Desmond is the administrator of the Hawaii State Laboratories Division, which is out in Pearl City. He comes to us from the California Department of Health, also Lab Sciences Division, and he brings over 40 years of experience to his position as administrator. And then Dr. Andrew Christian Whelen is the Vice President and Technical Director of Microbiology and Molecular for the Diagnostic Laboratory Services, also known as DLS. And if I am correct, I believe he was Dr. Desmond's predecessor. And in his new post, I believe also just over, maybe just making a year in that, he brings over 33 years experience to that position, having worked with the US Army as well. So I think we're really fortunate to have both of them with us. And without further ado, I'll let Dr. Desmond start us off with a few words about the current situation around COVID testing, a hot topic, of course, right now as we think about where we're at and where we're headed. So, Dr. Desmond.
We can't hear Dr. Desmond.
Yeah, I can't hear him either. Do you want to unmute yourself? If you go to your panel, you'll see the mute in the corner. If you click on unmute, you should be able to.
Can you hear me now?
Yes. Perfect. Thank you.
You can hear me now?
Yes.
Okay, good. All right, then I'll start. Are you going to change the slides?
Yes, I definitely will.
Okay, so you want to go to the next slide then, please?
Sure. Try to get this to cooperate with me.
Okay, just to kick things off, I'm not sure what I hear about, but I'll talk about what we're doing here, which is a real-time reverse transcriptase PCR. We've been doing that since February 28th. And we've gotten the reagents from the International Reagent Resource, and the instrument we use is the 7500 FastDX real-time PCR instrument. This testing was approved by the Food and Drug Administration as an emergency use authorization for testing of symptomatic patients only. And we work closely with the state's Disease Outbreak Control Division. So they have defined persons under investigation who have reasonable suspicion of having COVID-19. We test nasopharyngeal smears from those patients. And beginning sometime this week, we think we're also going to start testing specimens collected here on our site from healthcare workers and first responders. And this is only for symptomatic patients who have been pre-cleared and had their testing ordered by a designated physician. So we are doing testing to support our Disease Outbreak Control Division, but mainly the bulk of testing to support diagnosis and treatment is being done in private sector laboratories like Dr. Whelen's DLS. So we provide testing on a priority basis for our Disease Outbreak Control Division in support of surveillance and outbreak investigation and control. So next slide. Can you change to the next slide, please? I'm not seeing the next slide, are you?
Yes, it's the Abbott ID Now instrument.
Okay, all right, okay. Abbott ID Now instruments. So we have some of these as well. This is a newly released rapid isothermal nucleic acid amplification method. And it's very simple to perform, test one sample at a time. Looking at the cost of the kits, this is going to be somewhere around $40 for a reportable result. So we got 15 of the instruments that were bought using federal money from the International Reagent Resource. And we are going to distribute 12 of the 15 to other laboratories, including neighbor islands and to other healthcare systems in Oahu. So we're going to keep 3 of them for ourselves. These have a very limited reagent supply. So we have a commitment to get 5 test kits per week, which we're going to distribute to the other laboratories and keep some for ourselves. But 5 kits is only 120 tests per week. So 15 instruments and 120 tests per week. This is not high productivity for these products because of the limit in reagents available. I just discovered something about this today. The laboratory group tested a number of samples, including samples that had higher CT values above 30 by our routine RT-PCR method. And of these 8 samples that had smaller viral loads, because they had higher CT values, only half of them tested positive in the Abbott ID Now instrument. So it seems to have less sensitivity than the RT-PCR using. So that may mean that these will be used as a screening test, or that negatives may need to be repeated by a more sensitive method. It's a very rapid method, but it seems to be somewhat inferior in sensitivity to the RT-PCR that we've been using to date. So next slide, please. Okay, then I wanted to talk a little bit about antibody tests, and CNN did a bit on this, and there is the link that I've shared with you. And they called some of the tests crappy tests. So I think there's something like 80 of these antibody tests that have been brought to market. And many of them are lateral flow assays, which are very simple to do. But among the problems are that they have been misrepresented as diagnostic tests when they're not. And another problem is that people get infected with the coronaviruses that cause common colds, they may develop antibodies that can cross-react with some of the antibody tests. I think the better designed products are not to cross-react, but until we know which ones are specific to COVID-19, we can't really be sure that when antibody is detected, it's not really antibody to a common cold. So as I mentioned, they're not diagnostic tests, even if they're marketed. And one of the reasons is that patients may not become antibody positive for a while after they become infected. So somebody may get infected and develop symptoms, and antibody may not develop for several days or even up to 20 days later. We think in the future that antibody tests may play an important role. For example, we can use them to tell where COVID-19 has spread in a community. So there may be patients who were never tested. They may have even been at very mild symptoms and never been tested. But we'll be able to tell how widely the virus has spread. So that could be an important role for antibody testing. And then the criteria have not yet been established, but there's a possibility that antibody tests might go about returning to work, especially for healthcare workers. So that's what I wanted to toss out there, and maybe we'll have some discussion later on, but those are the ideas that I wanted to bring up. So that concludes my slides.
Thank you very much. Let me just ask everybody to hold questions until the end. We are dedicating at least half of the program today to Q&A. So let me go ahead and see if we can advance this slide. The technology is a little slow today, I think, with everybody on this call, which is great. Dr. Whelen, would you like to say a few words here before we move into Q&A?
Sure. Thank you so much for inviting me and Dr. Desmond to speak today. Do you hear me okay?
Yes, I can hear you well, actually.
Okay, very good. I plan on giving you just a timeline of the activities here at Diagnostic Laboratory Services in response to the COVID-19 outbreak. So back on March 13th, 2020, DLS began performing real-time reverse transcriptase PCR in a lab-developed test here at DLS for COVID-19 using CDC-developed materials on our Roche MP24 extractor and 480Z analyzer under FDA pre-emergency use authorization. Total test time takes about 5 to 6 hours, and the capacity was limited to 23 to 92 tests per day, 7 days a week, and overflow was sent to Quest. Before I continue, you can see over my shoulder is Dr. Amy Warren. She's the manager of molecular diagnostics here at DLS and was instrumental in not only bringing this test up and running, but the other tests that I will discuss in a few moments. Early on, DLS throughput exceeded Quest's throughput on the mainland, and at one point they became so backlogged we had to begin sending overflow to a second reference lab on the mainland LabCorp. So on March 17th, 4 days later, DLS joined only 38 other labs nationwide approved to perform the first commercial test available under FDA EUA, which is performed on the Roche 6800. Supplies were received on March 24th. Validation was started, completed, and go live was on the next day, just as supplies for the MP24 ran out. Allocated capacity is now 188 patients per day, 7 days a week. Although this week they doubled our allocation, We're not sure whether or not that allocation increase will be permanent at this point in time. We certainly hope it is, because the instrument has a high throughput that could potentially handle 940 tests per day over 2 shifts. On April 3rd, DLS received the first shipment of 120 Cepheid Gene Expert cartridges. This is a 45-minute molecular test, and we got notification that another 180 tests were allocated for delivery tomorrow. Initial rollout was at Queens Punch Bowl on April 8th, and we'll expand to Queens West next, and hopefully in the not too distant future, Queens North Hawaii Community Hospital on the Big Island. As Dr. Desmond indicated before, these rapid tests do have a lower sensitivity than the full extraction and detection systems. I believe the limit of detection for the Gene Expert is 250 copies, whereas we can routinely see detections in the other platforms in the neighborhood of 20 copies, 20 to 50 copies. As Dr. Desmond indicated, those are going to be important near the limit of detection. But what we've also seen in most of the patients that are positive, their viral loads are quite high. When Department of Health State Labs makes Abbott ID Now instruments and tests available as early as this week, we believe, we will likely locate one instrument at Molokai General Hospital and one at Queens West. This is the 5-minute PCR test, although it's important to keep in mind that negatives have to go the full course of the test. I think it takes about 13 minutes. We are also trying to negotiate with Abbott, working with Department of Health as well, and leaders here in Hawaii to try to increase the allocation of those Abbott products here. DLS has secured high priority testing on the Becton Dickinson BD Max system because of our willingness to assist with a situation in Guam involving several hundred cases on a Navy ship and the quarantine of about 3,000 crew members in hotel rooms in Guam. In case you didn't know, DLS has a central laboratory in Guam and provides reference testing for Guam, the Northern Marianas, and some of the other Pacific Island jurisdictions. Just a couple more comments in addition to those that Dr. Desmond said about the antibody tests. These unproven antibody tests have flooded the US market, which FDA has allowed if companies notify the FDA that a validation has been performed. They don't have to submit any data, they just have to notify the FDA. Many of these are rapid IgM, IgG tests produced in China and aggressively marketed to providers. Diagnostic labs cannot perform these tests because of federal rules requiring labs to perform validation tests, particularly if they're not FDA labeled. The good news is credible companies are seeking FDA EUA, and hopefully products become available in the next month or so. Once product has emergency use authorization approval, there has been one product that has received FDA EUA approval. However, it uses the same disclosures as the non-approved tests, and the performance characteristics reported in the package insert are quite disappointing. That being said, nobody can get a hold of these tests anyways. The company is indicating that they're not shipping, due to higher than expected demand and disruption in transportation. So that's been our experience here at DLS over the last few weeks, and it's a different game every day. It's been a pretty challenging, but very, very proud of the team that we have here. I believe we've accomplished an awful lot in a short period of time in support of the state's response to this outbreak. And those conclude my prepared comments.
Thank you, Dr. Whelen and Dr. Desmond. Let me just applaud you on behalf of Hawaii Public Health Association for all the work that you are doing. I know this is a crazy time and you must be working around the clock on this, but we are so thankful for your leadership and your expertise and for your willingness today to share all of that information with us. I appreciate you mentioning Guam, Dr. Whelen. We do have some folks with us from Guam, actually. So I imagine there are questions from them as well as others on the line. Let me go ahead and open it up for questions. Let's start by, if you want to ask a question, just put yourself on unmute. I think everybody's on mute right now. Just unmute your line and raise your question. We'll see how this goes.
How do you want us to tell you?
You can just go ahead and raise your question.
Okay, I put it on chat. I don't know how easily everyone can hear me. There's some reverberation from my side. But my question, and you can read it, is I'd like to know two things. One is, if you could explain which government office determines testing policy. I'm very interested in understanding the thinking around access to community surveillance testing, understanding that part of the issue is not having a great test or access to tests. But just let's assume that we have we have access, physical access to tests. Who's in charge of access to community surveillance testing? Who's in charge of determining the science behind this access? And with regards to my second chat question, it would be this would be the background, is that I saw that as of April 12th, DOH reported that a little over 19,000 tests were administered. I'm just wondering if you could comment on what it means and how many tests we need in order to understand the prevalence of community infection. Thank you. Thank you.
This is Ed Desmond. Can you hear me?
Yeah, I can.
Okay, good. All right, then I'll try to take a crack. That's a lot of questions.
Wait, I think you know what it means. Like, what's the policy environment and what's actually happening? You know, how can we make it work?
So we have been doing some surveillance. So one of the types of surveillance that we've done is that when specimens are sent to private sector laboratories with a request for respiratory virus panel testing, and they get a negative result, we've been asking that those specimens be sent to us, and then we've been testing them for the presence of the COVID-19 virus. We did that until recently. Now, mostly the private sector laboratories, if they get a negative by their respiratory pathogens panel, they're testing it for COVID-19 themselves. So we're in the process of trying to develop new surveillance protocols, but that's what we've done to date. So we've tested several hundred samples and with just a few positives.
So but on the DOH site, it said that 19,500 tests have been administered. What are who's been doing that testing? Is it not DOH? Is it the private labs?
The bulk of the testing has been done, as I mentioned, by private sector laboratories.
Okay, but in collaboration with DOH, because they're reporting it I'm assuming, tell me if I'm wrong, the DOH testing with the private lab testing together. And that
Yes.
someone must be reviewing this to establish community infection and figuring out what to do with that number and how to increase testing or something. Want to know who's doing all that? How's the private and the public sector working together on this? If you can comment on that.
Well, the private sector laboratories have been very diligent about reporting their results to the Disease Outbreak Control Division. So I'm very thankful to them for that.
Yeah. Okay. All right.
Yes, this is Chris Whelen. We do report all test requests, all negatives and all positives to the health department. And I think I can speak for the other laboratory networks. They're doing the same thing. So the DOH is getting the consolidated community-wide picture. Because the tests are limited, we're working at a very high level in the Queen system. DLS is part of the Queen systems.
Right.
For identifying the priority patients that we need to test on island, and then some of the overflow then go to the mainland reference labs because our demand do exceed our capacity at this point. That being said, we've partnered with other hospital systems, including our competitors, in the event that they need testing for their critical patients. We had an incident 2 weeks ago, I believe, when our competitor laboratories COVID-19 testing went down for 3 days, and we provided the testing for our competitor health system so that those critical patients were not disadvantaged as a result of that. So tight coordination between the laboratory networks, tight coordination with the state laboratories, and we're working as hard as we can to provide as much support to Guam as possible also.
Can you comment on, I'm a graduate student in sociology at UH and a public health person as well, but I'm interested in if you can say what populations on the islands have more access to tests than others, just given where the networks are and where the opportunities are to get tested. How could I find out about that? Or can you say? Or does anyone know right now?
I don't really have a good answer to that. So
Yeah.
I think that
I think one of the ways that some providers in the community are trying to improve access to screening and testing is through the drive-throughs. Those are kind of outside the typical hospital or private physician network, and it's a bit of an experiment, I think, as well. But that's one of the ways that some of the providers in the community are trying to improve access to not only just the testing, because a large number of attendees to these are not tested because they don't meet the testing criteria with the symptoms and the such. But we know how important it is to get testing available to some of those folks that may not have typical access to health facilities.
Finally, is there a COVID-19 kind of steering group within Dr. Park's office or somewhere that's kind of trying to keep tabs on how things are going, or is everyone kind of meeting occasionally? Can you tell me?
yes, Dr. Park's office is following up on all of the cases along with contact investigations to try and control the spread.
Right. So in terms of managing incidents and prevalence of cases, but in terms of setting up government response, is there like a group, maybe it's out of Sarah Park's office, I don't know, where there's a planner or some public health functionary that's trying to figure out just this question, where's access happening? How can we improve it? It may not be, may not be anyone yet. I used to work for county and state government, so totally understand in California.
As far as the specific question of expanding access, I don't have a good answer to that. I can tell you that planning and response to the outbreak is preoccupation of a large part of the state government. There are many people and many discussions on a daily basis.
Okay, but there's no like a point person or a point office yet?
Well, the Disease Outbreak Control Division, of course.
Okay, it would be the, okay.
Well, and this is Dr. McNeil. I could speak to some of this too, and that all the counties have an emergency response team. The health department has a response team. The state has an emergency response team. So all of the aspects of this outbreak are being coordinated by several different groups across the state.
How about others? I see a few questions that came in on the chat. Anybody else want to present those?
I see one from Nicole Apoliona, and this is about the capacity of the Abbott ID Now instrument. I think Chris mentioned that a negative may take as long as 13 to 15 minutes to get a result. But the limiting factor, I think that was actually anticipated by Nicole, was the actual availability of reagents. At the moment, we have a commitment from Abbott of shipping 5 kits capable of testing 120 samples per week. So that really is the limit. Another question was from Lauren Lee. Does insurance cover the cost of labs for COVID testing? For example, for drive-through testing? And I don't know the answer to that. I'm not familiar with the drive-through testing systems.
Considering specificity, we can refer to the.
Does anyone know the answer to that?
I think, I don't know directly, but I believe that the insurance companies are paying for appropriately collected samples when the clinical criteria are met. If those are being met in the through the drive-throughs, then I believe those testing costs are going to be covered. And I'm talking about the molecular tests. The antibody tests, probably not. In any screening of asymptomatic populations, I think are probably suspect as well, at least at this point in the response. Let's see, there's one about sensitivity and specificity of RT-PCR. So there's different ways that you can approach sensitivity and specificity. There's analytical sensitivity and specificity, and we've done those analyses. Some of those are wet lab. Some of those are in silico analyses to make sure that that the sequences that are used in the primers and probes are specific to the target genes and do not fold back over on each other or fold back onto any of the other primers and probes or anneal to closely related coronaviruses. And so we've done those wet lab as well as the in silico analyses. And I mean, we didn't see any cross reactivity, and our sensitivity as defined by limit of detection, went down to, at least on our commercial system, we hit 100% at about 20 to 60 copies and hit 2 out of 3 at the 2 to 6 copies. So now, from a practical standpoint, we move into the clinical sensitivity and specificity, and that's more an analysis of how the test performs within the whole context of the testing process, and that includes variables in the pre-analytic testing process. Was the patient symptomatic at the time of collection? How soon after symptoms developed was the sample collected? Was it an appropriately collected sample? Was it an optimally collected sample? All of these will influence the performance of the test. And those, I think it's still really too early to say how those variables are going to impact on the overall test process performance. I know I didn't give a number, and I know that's what everybody wants, but that's the reality.
That's because the number's not available, Chris. I think in the long run, we're going to be comparing the test results to the patient's diagnosis. An ideal assessment includes a review of each patient case by case and their clinical history and all of their laboratory results, and then we can evaluate how sensitive the test was in detecting patients who have that clinical diagnosis. It's early days, and I don't think that those kinds of studies have been done yet. There are anecdotes of people who have had negative tests by the RT-PCR and then later were positive, even though they were symptomatic when both samples were taken. So the sensitivity is not 100%, and I'll be willing to bet the specificity is not either. No laboratory test is perfect, and they have to be taken into context with clinical findings and epidemiology.
Just to add to the repeat testing strategy, so thus far we've tested 61, well, as of a couple of days ago, we had 61 patients that were tested twice and 4 patients that were tested 3 times. And in that small sample set, we didn't have any patients go from negative to positive. We did have 2 patients go from positive to negative. That being said, I always want to caution the use of a molecular test is not a test for cure. You don't want to test until a molecular test is negative, because nucleic acids are known to persist even though the viable microorganisms are no longer available. It should be minimal in an RNA virus, because RNA tends to degrade rather quickly. But that is the rule of thumb. Because
Nucleic acid amplification tests have problems with test of cure. Ideally, it would be good to do a study where we take a look at how long a patient is infectious by how long they're shedding viable virus. So that would require growing the virus in cell culture and then seeing if the patient is shedding viable virus. And those studies have not been done yet.
Thank you, Denise, for your kind comment about overview of sensitivity and specificity.
That was really good.
Yes, I saw that. what about this question from Tika Nisa, I think, if I've got the pronunciation right. Challenges with the virus on a chemical and or biological level. What issues are you or other doctors, researchers having in finding a vaccine? I'm amazed that with the advancement of our medical equipment, the virus is proving to be very hard to overcome. Do you have any comments? I know that's a little bit of field, but.
Well, I mean, I think we're seeing what a respiratory virus does in a susceptible population. Some viruses are more virulent and some are almost always asymptomatic. This one's a tough customer. It does cause fairly severe disease. It targets vulnerable populations, and I think the impact on the pulmonary system in susceptible patients is a real challenge for the providers out there, and it's I would imagine that part of it is the virus, part of it is the body's reaction to the virus, and sometimes if the body mounts a big inflammatory response, particularly in the lungs, that can be a real challenge. And so those are just some comments on what I think some of our providers are having to deal with in the more severe cases. In terms of potential vaccines, that's not an area that I'm involved with, but I would hope those that have studied these these more severe coronaviruses, like the 2002, 2003 original SARS, and the more recent Middle East respiratory syndrome coronavirus, that there's been some progress on trying to find some sort of vaccine that could be applied to this coronavirus. That said, there are many coronaviruses, and we could get lucky. A vaccine against one of the coronaviruses may provide some protection against other coronaviruses. There seems to be cross-reactivity in these antibody tests, so there certainly would be a silver lining if there was cross-reactivity amongst coronaviruses in vivo.
For vaccine studies, I think it's important first to establish that the vaccine is safe, that it doesn't cause any adverse reactions in people who get it. Another question to be answered is how well does it protect? When a coronavirus or other respiratory virus infects the superficial mucous membranes of the respiratory tract, it's not clear how effective humoral antibodies are. Antibodies circulating in the blood are against protecting infections at that site. I think I share some optimism with Chris. By producing deep-seated infections, I think it may stimulate strong antibody response, and it may be that antibodies will be effective. But that really still remains to be determined. There's a lot to learn.
So there's a question about conducting tests for representative or randomized samples of the population. I believe I was on a CDC town hall call a week or two ago, and I believe that CDC on a national level or even an international level, they're starting to look at seroprevalence, and this is, yeah, So I think when you ask how far away we are, I think there are public health officials that have these studies to some extent already underway. How far, perhaps the better question is, how far are we from drawing in conclusions from the data that these studies generate? And it's going to be a little while before we get the numbers necessary to draw those conclusions. I think, don't you think, Dr. Desmond?
Yes, I think one of our limitations is the limit on the PCR testing. To collect those samples, the person collecting the sample needs to don personal protective equipment, which includes mask and gloves and a gown. Those items are in very short supply. And so we don't want to burn through a limited supply of PPE to do a large-scale surveillance of people who are not, for example, not symptomatic. So that is one limitation that we face. I think once the antibody tests have been well characterized, then they could be very useful for this surveillance, randomized surveillance in a population. So collecting a blood sample doesn't require burning through PPE.
Or the swabs. The swabs are incredibly short supply. And so we want to make sure that those swabs and testing materials and PPE are there for the folks that are sick. And once, as Dr. Desmond indicated, serological test is available, that would be a much better tool in making conclusions on samples of the population.
Thank you for pointing that out. I think that's certainly the obvious limitation for us to move this out into the broader community, at least right now, the height of the crisis. Other questions? We have about 10 more minutes.
Somebody asked about testing in Hawaii as compared with other states. I will say that the number of tests by the molecular methods per capita in Hawaii are right up there. We're one of the states that's done the most testing per capita.
Yes, I think I read that recently, and that's certainly a testament to your work and the work of all the folks on the front lines in fighting this epidemic. Any other last questions?
I have a question. That I'm wondering again, that I think I heard you say that the criteria for COVID testing includes patients who are exhibiting symptoms. Did I get that right?
Yes.
Okay. And I'm wondering if this means that the 19,500 people who were tested mostly presented with symptoms. We can kind of assume that.
We hope so.
Okay, I assume it's probably somewhat mixed, but that's the idea. So I'm wondering, we know that patients can be infectious before the clinical symptoms appear. Is there talk about expanding the test criteria anywhere?
No, and for a couple of reasons. One is, as Dr. Whelen pointed out to me, our EUA, our emergency use authorization for the method that we're using, is for testing symptomatic patients.
Right.
And so if we test asymptomatic patients, we go beyond the EUA.
Understood.
And the other is the shortage of the PPE, as we've already discussed.
That's what I figured. Is this the case around the country where the priority for testing are people with symptoms?
Yes.
Okay. Okay.
Generally, yes.
Okay,
There
and I
may be exceptions.
Okay, I just wasn't clear about that, so thank you, that's very helpful.
So there's a question, if labs are using their own EUA test, is it safe to assume that the sensitivity and specificity may vary across the states? If they're going to develop, as DLS did, develop our own EUA test, we have to demonstrate to the Food and Drug Administration what our performance characteristics are. And it is a little bit different in that we don't produce a package insert. What we have done though, and I believe it was the links were provided, we provided some technical bulletins, and in that technical bulletin from a rather high level, we provide the performance characteristics as we explain them to the FDA. And so there is going to be some variation, but I believe the FDA is to some extent comparing any other submissions to the original CDC assay, and that the design of that assay is excellent, and which is why we use the materials and we just validated it on the instruments that we have here. But there is gonna, and I believe DLS is the only one that did our own lab developed test. When we talk about EUAs or the use of EUA products, those are products that the manufacturer has gotten the emergency use authorization to go ahead and deploy to laboratories. And so those performance characteristics are also going to be provided in the package insert, and what we're going to see is a bit of a loss of sensitivity in the more rapid tests because their detection threshold is higher. In most symptomatic patients, we're seeing very high virus titers, but if it's a patient that is sampled a little too early or a little too late and the virus levels are not as high as we typically see, then those rapid tests may miss them. The good news is they're probably not near as infectious as the other folks that have a lot of virus.
Yeah, so at least if they are testing negative by the less sensitive method, it's because they're only shedding a small amount of virus and hopefully less infectious.
Trudy, I'm glad your test was negative.
Yeah, and I see this note from our friend on Maui that the drive-through testing, there was no charge. Tests were provided by the government. It took a week for results. Calls for triage and appointment times were given.
Sorry.
Any final questions before we close the webinar?
I do want to say something that's been a rather hot topic clinically. We did experience a backlog of our mainland reference labs early in the early in the testing process. Those backlogs have pretty much resolved themselves. So even though we have to send our overflow to U.S. mainland labs, they're typically turning around those results in 2 to 4 days. And so that's great effort on their part. The testing that we do in-house is typically same or next day testing. So that was the early rapid testing. And now that they'll have hospital-based testing, that's the new rapid.
I guess I'd like to give a shout out to our laboratories division. I think they've been doing a great job. They've been working 7 days a week and churning out the results in a similar turnaround time to what Dr. Whelen just mentioned. If we get a sample by 11:30, we report the same day, and if it's later than that, we report it the next day.
So Denise, I see your question about estimated ranges for sensitivity and specificity based on our internal validation studies. The test performance doing spiking studies as well as the in silico analysis, I kind of hate to say this in a public forum because it's not reality. We didn't see any cross-reactivity. We did see 100% specificity and 100% sensitivity down to our limit of detection. But then below the limit of detection, then we're not going to be 100% sensitive. And you include some of those pre-analytical variables, that's going to impact the sensitivity. The specificity is very good. If you think in terms of specific primers and specific internal probes and 2 different targets, a lot of things have to go wrong to generate a false positive. Now, having said that, remember some of the pre-analytical things that can go wrong. If you have specimens leak in transit, and say it's a high titer positive, it leaks in transit and potentially contaminates other samples if they're not packaged properly, individually bagged. For example, we had an instance of that just this past weekend where one of the drive-throughs had all of the specimens in a single bag, and which would have been disastrous had any one of those specimens leaked. So, those are the things that contribute to the reality of operational sensitivity and specificity, as well as your, and then your predictive values are dependent on your prevalence, which right now our prevalence is incredibly low. I think only once did I see a test run that exceeded 5%. Everything else is in the 2 to 4%, and these are in symptomatics. So consequently, the negative predictive value is really, really going to be good, 99.9 whatever. With the specificity, I think the positive predictive value is actually better than you would normally expect from the laboratory, just based on the assay design.
Thank you.
You're welcome.
Thank you for illustrating that, Dr. Whelen. It looks like we're at the hour, and with respect to everyone's time, especially these leaders in lab science, let me just take a moment to thank you both for this learning opportunity. I think it's been an excellent chance to just raise questions with you who are seeing some of the many issues around testing firsthand. So Thank you so much for sharing your time with us, and thanks everyone on the call for joining us. I hope you're all well and staying safe, helping our community to stay safe. So with that, we'll end the call, and we'll do our best to get the audio recording on the website within the week. So thank you all for joining us. Aloha.